What is the significance of the posterior condylar axis as well? That's something else that we uh, see. When you read about just um, the surgical technique of um, total knee arthroplasty, is something that comes up. Can you explain that a bit more?
Yeah, so the looking at the posterior condyles, they're actually internally rotated about 3 degrees. So when you're setting, so you've made your distal, the way I do, I prepare the whole femur first. So you've made your distal femoral cut, it's 5 degrees, it lines up with the mechanical axis, points straight to the femoral head, great. The next step is, for me, setting our femoral rotation. So you'll see it in every question. Don't internally rotate the femur. That causes patella maltracking, causes subluxation, risk for dislocation. But why do we internally rotate, or why do we externally rotate it to 3 degrees? Why do we choose that number? So that the posterior condyles are actually internally rotated to 3 degrees. So to compensate for that, we're actually externally rotating the jig by 3 degrees, and basically the 3 degrees cancel out, and that gives us a flat cut, which everything we're trying to do is we're trying to get rectangular spaces. So we're trying to get a rectangular extension space. We're trying to get a rectangular flexion space. And this is going to give us a balanced knee. And a balanced knee is going to give us the best outcome for the patient and give them the most stable knee that we can. And so that's why we externally rotate the jig by 3 degrees. Now, the pitfalls that you have to kind of watch out for is if you have a hypoplastic lateral condyle, then the posterior condyle axis is actually more than 3 degrees internally rotated. It may be 5 degrees, it may be 6 degrees. So then we would add more external rotation into our jig. And that makes up for that extra degrees. And so there's a bunch of different techniques to accomplish this. You can take a small little wedge, you can put it into the lateral condyle. You can line up your external rotation with the epicondylar axis. You can look at Whiteside's line to make sure you're perpendicular to that. And some people will even make their tibia cut first and then make their flexion cut off the perpendicular to the tibia so that you have a rectangular space. So there's basically 4 ways to kind of set your rotation. For me, if it's a little hypoplastic, I just like to make sure it's, I may do 5 degrees of external rotation, and I just double check it with the epicondylar axis and with the Whiteside's line to make sure that I'm not internally rotating my femoral component.
Yeah, and actually, I think that's pretty high yield about the hypoplastic condyle. So, what if you don't appreciate that you have this, that the condyle is hypoplastic, and you don't make the appropriate adjustments, and you treat this like a normal knee? What deformity will you most likely see after you make your cuts if you don't take that into consideration?
Well, I mean, once you do enough of these, you'll kind of see, and sometimes you can kind of notice, you'll be like, oh, my component doesn't look externally rotated enough, or that's not lining up with the epicondylar axis. But it's not so much deformity, but you will be internally rotating your femoral component, which the ultimate kind of downside of that is your patella, your trochleal and your implant will be shifted more medially, and your Q angle will be increased. And so your patella will be more likely to sublux out laterally. And so you don't want to do a whole total knee and then you find out you're flexing it up to 90 degrees and your patella is popping out laterally. That's like one of the worst complications you can have. The other things, there's kind of slight subtleties to think about. So if you internally rotate your component, then you're actually closing down the medial space a little bit and making it a little bit tighter in flexion on that medial side. If you over externally rotate your component, you're actually closing down that lateral space in flexion a little bit. And those are kind of the subtleties you get into when you're balancing a knee. But really, the primary goal and the easiest check is, set your guide at 3 degrees of external rotation. Realize if it's hypoplastic, you may need a little more. And before you pin it and cut it, make sure that you line up with your epicondylar axis and you line up with Whiteside's line.
That was I think that was a great explanation. And so just to quickly sum up some of like how we just kind of talked about how we make some of our different cuts is on our AP is we're trying to recreate again that mechanical axis. So we make our cut in 5 or 6 degrees of valgus in order to recreate our mechanical axis using our anatomical axis as a guide. And then to help control rotation, I know there's a lot of different techniques, but using our transepicondylar axis, our posterior condyle axis is 3 degrees internally rotated. So to compensate for that, we put 3 degrees of external rotation on our jig, or it can be 4 or 5 degrees if their lateral condyle is hypoplastic. But pretty much we want that cut to be parallel to our transepicondylar axis. And we don't want to internally rotate them too much, because then that'll lead to patellar maltracking because you have increased Q angle, and that can lead to complications post-op.